We've heard from politicians, physicians, obstetricians. Now it's time to hear from a maternal medicine midwife, one of the key roles in delivering an effective obstetric medicine service. Ms. Sharon Elder is a registered nurse, a registered midwife, a professional midwifery advocate, and a non-medical prescriber. She leads the South East London Maternal Medicine Network as lead maternal medicine midwife. Sharon is going to speak with us today about her role as a specialist midwife in obstetric medicine and what her days are like. Thank you, Sharon.
Good afternoon. Thank you, everyone. Firstly, I have to clear up something. I was not late, okay? The plan was always for me to go to the Wildfowl Trust, not to go to the pitch league. I was on time. Right. Let me put my glasses on. So, as Ciara said, I'm the lead midwife for the South East London Maternal Medicine Network. So in the UK, there's 14 of these networks, and we, Kathy, Sonji, and myself, lead one of those networks. And the role of the midwives within these networks is pivotal, is really, really important. And I think to understand the impact that midwives have within these networks, we need to start from the beginning. So I thought we'd look at the booking process. So it starts with a self-referral. So in the UK, you become pregnant, you go to the chemist or the drugstore, as we say in Trinidad, you get a pregnancy test, you're pregnant, so you then fill out a self-referral form. That's an online referral form. That then you put all your information about your previous pregnancies, any medical conditions that you may have. And then a plan is put in place since COVID, whether or not that first appointment is going to be by telephone or whether it's going to be a face-to-face appointment. So the length of time that's allocated to this appointment is based on the information that's put on that self-referral form. So a lot of it is dependent on what the woman has put on the form. And there's variations. Variations within the networks, variations within units across England. So I hear you asking, what is a booking appointment? I'm saying it because this is my normal language, and some people in the room understand exactly what I'm saying. But a booking appointment is the first appointment that a pregnant person has with a midwife. Ideally, that appointment should be by the 10th week of pregnancy, before the 10th week of pregnancy, and the reasons for that will become a bit clearer as I go on. The appointment is usually an hour to an hour and a half, and that all depends on that information that's given on that self-referral form. So we have the National Institute for Health and Care Excellence, NICE, and this guides our practice in terms of what we do when it should help us to provide the best care, to spend the money that's allocated in the right way. Doesn't always work, but that's what it's there for. So at the first antenatal booking appointment, you, as the midwife, you're asking about the history of the woman. So the woman's medical history, the woman's obstetric history, the family history of both biological parents. So, you know, if it's a first pregnancy, that's easy. Never been pregnant before. I don't have any medical conditions. There's no history, not much. So an hour is enough time to do that. But if you've had 5 babies before, and 2 or 3 of them are cesarean sections, and you've had complications during those pregnancies, you have to go through each one of those pregnancies. It's not good enough just to say, I've had 5 pregnancies. Each pregnancy, before pregnancy, during pregnancy, after pregnancy, you need to know what's happened at each phase of that particular pregnancy. Even if a termination was had, even if there was a miscarriage, you have to go through each of those pregnancies. That takes time. Then you go through the medical conditions for that particular woman, go through her medical history, then you go through the medical history of her mother, her father. And there's questions you'd also ask about the partner. So based on that, as I said before, you would offer a particular length of appointment for her. This is going forward, yes? So you've assessed what's happening with her at the booking. You're now planning going forward what will be appropriate for her. So after discussion with the woman, you then decide, actually, we need to let the GP also know about this. In years gone by, when you became pregnant, you went to your GP, the GP would do the referral, the GP knew that you were pregnant. That's now not how it happens anymore in the UK. The woman does everything, then the GP may or may not find out. But we have to engage the GP because we need the GP to manage if there's any complexities for the woman. So these are the examinations and investigations that we have to do at that first face-to-face appointment. Remember I said the first appointment might be by telephone. So if that appointment was by telephone, the first time you see her face-to-face, you need to offer the blood test to check for the full blood count, the group and safe, the rhesus status. You also need to discuss and share information about screening programs. There's really thorough screening programs for infectious diseases in terms of HIV, syphilis, and hepatitis B. There's also the sickle cell and thalassemia program, and there's the fetal anomaly program. Now, these are all opt-out programs, so women can choose to accept or decline any of these things. You have to gain consent. We're not meant to just do things to people. They do have choice. So then what? So you've done all of this. If this woman is considered to be a low-risk pregnancy, stays with her midwife throughout her pregnancy. The midwife cares for her antenatally, intrapartum, postnatally, does not see a doctor. There's absolutely no need. Midwives are the experts in normality, so doctors don't get involved. However, if there's an issue, you have to then refer to the obstetrician. Or you may refer directly to the obstetric physician or another physician, but you would include your obstetrician also. Those two people are key. It all depends on what you've picked up. So, if we've done all these things, have we actually considered obstetric medicine? And some of us say obstetric medicine, some say maternal medicine. We're talking about the same thing, just to clarify. So I think you only do that if you ensure that you spend the correct time in terms of the booking process. You've allocated the right amount of time to elicit the appropriate information to ensure that you then put the woman on the right pathway. You have to have the right staffing in place, and we know that's a challenge. Doesn't matter where you go in the world, that's a challenge. Apart from the States maybe where they've overflowing with doctors at least. But it's a challenge everywhere you go. The experience of that midwife who is performing that booking and the education that that midwife has had pre-registration and post-registration. These are all really important factors to consider, especially when you're thinking about an obstetric medicine service. The availability of the past medical history for that midwife. Remember I said the appointment may be face-to-face, it may be on the phone. So you may not have all the information that you require. And key to all of this, which has been mentioned several times before, is the understanding of the red flags. So that if one were to pick up on any of these red flags, what do you do then? What happens next? So some of the things that needs to be considered when you're thinking about midwifery input into obstetric medicine is how are women accessing maternity care when they first become pregnant? What are we encouraging them to do? It's really important to get them into the system as early as possible. We need to empower them so that they actually know the need and the importance of getting into the system early. Because we know if they get into the system early, we can start managing conditions which may not have been managed previously. We can start them on medications to maximize their outcomes for the current pregnancy and future pregnancies. We need to look at the content of the midwifery programs. What's happening currently, what's available once someone has qualified, what sort of pathways are in place for people, midwives, who would like to go down the obstetric or maternal medicine route. Because you do need some additional training. Just like the physicians need extra training, just like the obstetrician needs specific training, our midwives need specific training because they are the first point of call, first contact, and if the midwives understand and are aware of what is not normal and don't normalize things, they can then escalate appropriately. So that takes me right on to maternal medicine midwives. These are key to the running of the networks that we lead. When I first started in post, my post is, as we say, for Southeast London. I am the lead midwife for the network. We have got 5 hospitals in that network. One hospital or 2 of the hospitals have got teams of specialist maternal medicine midwives. Those are the 2 tertiary centers within our network. And then we had 3 district general hospitals without any specialist maternal medicine midwives. And one of the main things I wanted to achieve was to ensure that each of those hospitals had at least one person who could coordinate the needs of those women. Thankfully, we've been able to achieve that, and we've got 3 of those 3 midwives in post. The hope is that that will go on and carry on to become a team with time. But as it stands, 1 midwife in post coordinating the care for those women is going to make a big difference, ensuring that they get into the right pathways and see the right people at the right time. I've already touched on this. It's really powerful when you empower people. Sonzi's touched on it, so has Kathy. I think we're singing from the same hymn sheet. If you empower people, they are able to then follow on and do what is required to maintain their own health. And getting the right person to do booking, if you have all these things in place, you will get the right person to do the booking, who's got the appropriate knowledge and skills, and then can refer to the right pathway, go to the right clinic, consider all the complexities that exist so that the woman then gets the right care. So maternal medicine midwives, they caseload. Now caseloading can be a midwife or team of midwives looking after a group of women antenatally, intrapartum, and postnatally. Or they may be a midwife who is coordinating the care for a group of women just antenatally, simply because of funding or various reasons. So there's different models that you can use. Caseloading is varied. You can use different models within caseloading. Maternal medicine midwives, they are that point of contact for women and birthing people. Or if you've come into the pregnancy already with complex medical needs, or you've developed conditions during the pregnancy. They're also familiar with red flags, and they're able to escalate their concern. And they know how to safety net women. More specifically for myself as lead midwife, I work very closely with Sanjay and Kathy. As a team, we provide system-wide education. We do education specifically for midwives and nurses because we know that often they are the first people that women contact. And if they don't understand that, by the time the woman may be sent home or be given the wrong advice, so by the time they get to the physician, we've missed opportunities to impact on their care. Kathy's already touched on this, but we share regional protocols and guidelines on best practice. We support the management of acute clinical needs and support the development of maternal medicine networks. We have got responsibilities for other networks in England. And I really, really do champion maternal medicine midwives at the spoke sites. So the spoke sites, so we at St. Thomas's, we are the hub site for the network, and all the other hospitals around us are called the spokes. So champion in the midwives on the spoke site is really big on my agenda. And the focus on equity of access to expert advice is key, because we can't give the same to these women. You have to put in extra layers for them to achieve good outcomes. That's been demonstrated in all the talks that have been given today. And I'm also involved in governance, which, as we know, is key to anything going well. So people, just like a little reminder, really, just to say, people have the right to be involved in discussions, and they've got the right to make informed decisions about their care. So when we start talking about developing obstetric medicine societies, we must remember to keep the woman at the center, because that's why we're doing what we're doing. And it's kind of difficult because, as clinicians, we want to recommend, we're recommending all these things that we know to be right or believe to be right, but the woman has also got her beliefs. And you have to balance that, because at the end of the day, all you want is a good outcome for mum and for baby. So you have to get the balance right. Thank you.